if we talk about the problems of the stomach, so we must know another basic concept that whenever we are talking about gastritis, we have to know why actually in which layer this gastritis is occurring. As we know in our GIT, we have 4 layers, that is mucosa, submucosa, musculus propria, and adventitia or serosa, whatever you say. But whenever we are talking about gastritis, we'll only talk about the mucus layer. We'll talk about the mucus layer, and you all know that the mucus layer has another 3 layers inside it, and the very first layer is that epithelium lining, and the stomach has simple columnar epithelium. Okay, as it is simple columnar epithelium, so we'll come to this later, but first of all we have to think about this mucus layer. You know, this mucus layer is very much important. Why this is very much important? Because we have told already the gastritis means it is actually having some problems in its mucus layer. So mucus layer is basically important, but we have to also know that a person or a patient doesn't develop gastritis or doesn't develop any problem of the stomach with all on a sudden. It takes some certain time period. It takes some certain time period for making an inflammation there. So if he or if a patient is exposed to some injurious agent or exposed to some factors, what is the another factor that is protecting actually mucus layer, and the patient is coming to us a period later whenever this all period he or she or that patient is exposed to that dangerous or exposed to the hazardous factors. So in short, I am talking about what are the factors that is protecting actually mucus layer. This is very important. You have to know. This is another basic concept, because whenever we have gastritis or whenever we have inflammation or whenever we have a very basic terminology that is peptic ulcer disease or PUD, this means there is having an imbalance. There is having an imbalance between the protective factor and the destructive factor of the stomach. So we'll come to the destructive factors later. So what can cause this damage to the mucus layer of the stomach? Let's know that protective factors. So if we talk about the protective factors of the stomach, or very specifically the protective factors of the mucus layer, first come that the mucus secretion. We all know that mucus secretes from here. Another thing, there is a bicarbonate ion. What? Bicarbonate ion in mucus. Another thing here comes, that is prostaglandin. What? That is prostaglandin. What prostaglandin actually does? Prostaglandin actually supports from the behind this mucus layer. Prostaglandin supports from behind this mucus layer. Another thing or another protective layer is the rapidity. Rapidity of whom? Rapidity of the cells or rapidity of the surface epithelium of this mucus layer. And there are so many protective factors, but these 4 are the very important protective factor you must know. And whenever in case of your written exam or in case of your prof viva exam, teacher will ask you or the external will ask you, tell me some protective factors of the gastric mucosa, then you must tell these 4 first. Number 1, mucus secretion. Number 2, bicarbonate rich ion in the mucus. Number 3, prostaglandin in it. And number 4, rapidity of the or rapidly proliferating cell of the mucus layer or mucus epithelium, that is simple columnar epithelium. Simple columnar epithelium is a very rapidly proliferating cell. Okay, so we have already come to know that what are the factors that is actually protecting the mucus layer or protecting the stomach. Fine. Now let's come to the another factor that may cause the injury of the stomach, or we will learn how this factors actually causing injury to the to our stomach. Fine. First of all, so now we'll discuss about the destructive factor. So let's write it with the red one, the destructive factor. First of all, in case of destructive, in case of Western country, not in case of Indian subcontinent, we don't find so many patients of this here. In respect of Bangladesh, so there are so few patients this first factor, but Mr. Robbins has written it in first. That one is alcohol. So Question is how alcohol is damaging these mucus layers. And I have told you in few earlier that any factors or any patient never come to us with a one day problem that I have taken alcohol yesterday and I am facing some problem today. No patient will come to you like this. So if a patient or if a person has a history of nearly 2 or 3 years of alcohol consuming, this alcohol, what does alcohol do? Alcohol goes to stomach and alcohol goes to this mucus layer, touches the mucus layer, and alcohol touches the mucus layer, then it causes irritation there. So if you are taking alcohol 2 or 3 years randomly, continuously, so you are actually causing irritation for the 2 or 3 years continuously. So when you are continuously or chronic making irritation in that layer, it causes damage to the mucus layer. And when the mucus layer damages, in response of damage to the mucus layer, inflammation occurs, and we call it inflammation of the stomach, that is gastritis. This is very simple concept. Let's come to another concept, another factor. What is this? That is drugs. This one is very important in respect of Indian subcontinent or in respect of our country or your country, because now I am telling about a drug that is very common. We take it usually. In fact, many person take it usually with very less pain. Okay, so what is the name actually of that drug? That is NSAIDs. NSAIDs. You all know that NSAIDs means simply painkillers. Painkillers. Painkillers means naproxen, ibuprofen, and so many names you know. So actually, when a person is taking drugs, actually painkillers or NSAIDs, it may cause gastritis in case of chronic user. But question is how NSAIDs or how painkiller can cause gastritis in case of a patient? Let's learn this. If you know or if you remember the simple pharmacological concept or simple pharmacology of painkillers, so you can know that these NSAIDs or painkillers, they inhibit an enzyme that is COOX, that is cyclooxygenase enzyme. What they do? They inhibit the enzyme. They inhibit the enzyme. When cyclooxygenase enzyme cannot be synthesized, it cannot synthesize another component that is PG or that is prostaglandin. So if you are lacking prostaglandin, what is the problem? The problem is, I have told you here, in case of protective layers, that we have heard prostaglandin. What does prostaglandin do? Prostaglandin actually supports the other protective factors. It actually works as a backbone, works as a support. So when you are having less prostaglandin because chronic use of painkillers cannot synthesize the prostaglandin, then you are having less prostaglandin, and less prostaglandin causes weakness of the mucosal barriers or mucosal protective factors. And when the mucosal protective factors becomes weak, you develop gastritis. Very simple concept. Okay, drugs. Another thing is anti-cancer drug. Anti-cancer drugs. A patient with cancer when come to us, we usually use anti-cancer drugs, but these anti-cancer drugs can also cause gastritis in those patients. So, but question is how? Let me tell you what is cancer actually. Cancer is uncontrolled mitotic division. So there must be some rapidly proliferating cells, and anti-cancer drugs or anti-cancer chemotherapy, what this chemotherapy does? Chemotherapy actually inhibit, let me write, inhibit. What they inhibit? Inhibit the rapidly proliferating cells. They inhibit the rapidly proliferating cells. But it is very unfortunate that the GIT mucosa has also a kind of rapidly proliferating cells, and that one is the epithelial lining. I have told you that is simple columnar epithelium. So when anti-cancer drug we give a patient, they inhibit the rapidly proliferating cells. They, in one hand, inhibit the cancer cells which are rapidly proliferating, but they cannot differentiate the normal cells of our body. So what they do? They also causes the mucosal cell destruction. So when the cells of mucosa are actually destructed, there must be gastritis because the protective layer has already gone. So in case of compensation, there will be an inflammation, and we call it gastritis. So till now we have learned two things or two factors: how alcohol is causing gastritis. Then in case of drugs, how NSAIDs or painkillers is causing gastritis, or anti-cancer drug or chemotherapy, how it is causing gastritis. Now let's jump to our very third point or third factors. What is that one? That one is the uremia. Uremia. I hope you know what is uremia. Uremia. Let's break this word. Uremia. What does this mean? Uremia here, it is actually NH4, that is ammonium ion. And emia. What does emia mean? Emia means increase in blood. Something has increased in blood. So we use that term emia. So uremia means a patient with having ammonium ion in blood and it has increased rather than normal. That is uremia. So what is the relation with uremia and gastritis? What is the relation actually? Can you imagine? Let's talk about this. What does uremia do? What does uremia do here? Uremia doesn't do here. Actually, main culprit is the ammonium ion. This ammonium ion has a very enmity with the bicarbonate ion. If ammonium ion is present there, the bicarbonate ion cannot stay there. So they have very much enmity with themselves. Think about it. And we have already knew that bicarbonate ion is one of our protective layers. Protective layers of mucosa. Protective layers of mucosa. But actually what happens here is ammonium ion has already increased so much in the blood and the patient having uremia. So if there is so much ammonium ion in blood, the bicarbonate ion will start losing. The bicarbonate ion will start decreasing. And when this bicarbonate ion starts decreasing, the protective layers of the mucosa is also becomes weak. And when this becomes weak, the patient develops gastritis. Simple concept. We have already learned three factors. Let's jump to our fourth factors. And this fourth factors is very very interesting factors. In fact, we all have these factors. What is this? That is stress. So you must be thinking, yes, we all go through stress daily, every morning. In fact, the medical students, they undergo stress when they woke up from bed in the early morning, as after some time they have to attend their lectures at 7 o'clock, attend their items, attend their cards, attend their terms, and then this stress continues until he or she goes to the bed. Then again this cycle repeats. Okay, so we have so many type of stress. In fact, we have some mental stress. Let me write there. Okay, this is a very interesting thing. We have mental stress, then we have some physical stress. Okay, so I will tell you every mechanism of stress, how stress occurs or how stress makes the gastritis. But very first of all, I will tell you about the generalized concept of stress. All stress together. What does stress do? When we are having stress, it can be either mental, either physical, or any type. When we are having stress, we have splanchnic vasoconstriction. Okay, we have splanchnic vasoconstriction. Now, what does this word vasoconstriction means? Vasoconstriction, the word means we have a normal blood vessels like this. Okay, we have a normal blood vessel like this, and vasoconstriction means somehow the blood vessels has become narrow. So this example or this picture describes the vasoconstriction. But why stress causes splanchnic vasoconstriction? Because when we are having stress, we release of the endothelium cells within the blood vessels. The endothelium cells within the blood vessels, they release a substance that is endothelin 1. And this endothelin 1, it is actually responsible for, in one hand, vasoconstriction, and in another hand, this endothelin causes direct mucosal injury. Direct mucosal injury. So when some factors is causing direct mucosal injury, so obviously we'll have a gastritis. So this is the very basic mechanism, or this is the very simplest mechanism of stress, all kind of stress, what is happening here actually. Now let's talk about some different type of stress, or let's talk about some very special type of stress. Suppose a patient is in ICU. ICU. A patient is in ICU. That means he or she is in intensive care unit. So it is a stress for him or her. So if he or she or the patient is having a stress, whether he is admitted in ICU, obviously this mechanism will occur there. So when we manage a patient in case of ICU, suppose a patient came to us with pneumonia and we admitted him into ICU. So we'll give him the treatment of pneumonia, and also we must remember that as it is a kind of stress, so he may develop gastritis. So we also treat the patient with anti-ulcer drugs. Anti-ulcer drugs. You must remember that if a patient with ICU, then you must manage the patient with anti-ulcer drugs. Fine. So it is one kind of stress. There must be another kind of stress. Suppose you have a patient with burns. Okay, burns. So if you have a patient with burns, so burns means suppose all of his body parts have burned. So if a patient of burns come to you, there must be what happens. Burns patient in a body of burns patient, there must be dehydration. Dehydration. The very basic physiology in a burn patient, he will have a dehydration. If dehydration occurs, dehydration means his blood volume decreases. If blood volume decreases, obviously the stomach, it will also get a less blood supply. Okay, because the whole body blood volume has decreased. So stomach, how can stomach get its proper supply? So the blood supply of the stomach has decreased at its least level. Okay, if the stomach is not getting proper blood supply, then what happens? What happens actually? The epithelial lining or epithelial regenerative capacity, it also decreases. The epithelial regenerative capacity is also decreased. And also bicarbonate ion, it is also decreased. It decreases as well. So if a person is having burn, he is dehydrated. So dehydrated means his blood volume has decreased. Blood volume decreased means that patient is not getting enough blood to its stomach. So it means actually it decreases the epithelial regenerative capacity, which ultimately decreases the bicarbonate ion as well. Now, if we go to our first slide here, in case of protective factors, I have told you that the blood supply means increased mucosal blood supply is another protective factor for mucosa of the stomach. So here we have actually three protective layers and weakening. What are this? Stomach is not getting blood supply properly. So it is actually one of the protective factor that is decreasing. Another is epithelial lining. Epithelial lining is also decreasing. Epithelial regenerative capacity has decreased. So another protective factor is weakening. Then the bicarbonate layer or bicarbonate ion is also decreasing. Then the third protective factors is weakening. So when you have, or when the patient had so many protective factors are decreasing, ultimately the protective layer will be broken and the patient will develop gastritis. And ultimately this gastritis will lead to an ulcer. And we call this type of ulcer with a very special variety, that is Cushing ulcer. You must have heard the word Cushing ulcer. Now you know what is actually Cushing ulcer and how it actually occurring. So if a person develops an ulcer and the person gives you a history of burn, then it must be a Cushing ulcer. Or if someone asks you, tell me about Cushing ulcer, you can know the pathophysiology of this. Okay. Now we'll discuss about another. Another type of stress. What is it? The another type of stress, it's intracranial tension, increased intracranial tension, cranial tension. Okay, that is ICP or ICT, intracranial tension. If someone is having his intracranial tension increased, what happens actually? It ultimately stimulates the vagus nerve. What does it do? It stimulates the vagus nerve. It is not a problem if vagus is stimulated. Vagus maintains some nerve supply in our body, and it has also supply in stomach. But when the vagus nerve is stimulated due to this increased intracranial pressure, this vagus nerves actually causes increased secretion of acetylcholine as well as increased secretion of gastric acid. Gastric acid, that is hydrochloric acid or HCl. And as it is having or it is causing increased gastric acid, ultimately what occurs? The systemic acidosis. Systemic acidosis occurs. When systemic acidosis occurs, ultimately it also damages the gastric mucosa. Damages the gastric mucosa. Okay. When it damages the gastric mucosa, ultimately gastritis occur. Okay. But this type of gastritis also turn into or convert into an ulcer. And this type of ulcer, we also tell it a very special way, that is curling ulcer. That one is the curling ulcer. Curling ulcer. So you have already knew this name, curling ulcer, but probably we didn't know how the curling ulcer occurs. So this is the way, or this is the system, or this is the pathophysiology, how Cushing ulcer occurs and how curling ulcer occurs. And let me tell you another thing, or your teacher might ask you in your viva that tell me what are the sites of Cushing ulcer and what are the common sites of curling ulcer. So in case of Cushing ulcer, you must know that Cushing ulcers generally occurs in gastric, duodenal, and esophageal region. But curling ulcer, it only occurs in case of first part of duodenum. It means D1. So till now we have discussed about stress, and in respect of each type of stress, the important one is the how Cushing ulcer occurs and how curling ulcer occurs. Let me recap this again. If a person of burns came to you, he must have some dehydration. Dehydration means his blood volume has already decreased. His blood volume decreased means the person or the patient is getting least blood supply in his stomach. That means the epithelial regenerative capacity will automatically decrease. And if it is decreased, then automatically the bicarbonate ion will decrease. So here the patient is lacking of three protective layers. That one is the rich blood supply, then epithelial regenerative capacity decreased, and bicarbonate ion is decreased. So the patient will develop gastritis and it will ultimately convert to a ulcer, and we call it a Cushing ulcer. Then another type of stress, that one is intracranial tension or increased intracranial tension. If a person having increased intracranial tension, the vagus nerve will be stimulated and it will cause increased secretion of acetylcholine and increased secretion of the gastric HCl. And this high amount of gastric HCl will ultimately cause systemic acidosis. And when systemic acidosis occurs, it directly damages the gastric mucosa. And when the gastric mucosa directly damages, the gastritis occurs. And ultimately, it also converts into another type of ulcer. We call it curling ulcer. And the very common site for curling ulcer is the first part of the duodenum. And the very common site of the Cushing ulcer is the gastric, esophageal, and duodenal site. Okay. So now we have learned this. Now, it is very common question, as you are going to be a doctor. Tell me, if a patient comes to you, what will be his complaints or what will be your symptoms? What a patient will come to you and tell you that, my doctor, I'm having this problem. So what are the symptoms of this gastritis? Okay. Now let's talk about the symptoms. There is nothing about memorizing of the symptoms. Why? Because if the patient is well educated, So he or she will not delay, come to you early, okay? Or he or she may not come because in early stage it's asymptomatic because of this strong protective layers. The damaging factors have not weakened the layers so much that the patient is having some symptoms. So he or she may come later to you. So first of all, this is asymptomatic. Asymptomatic. Fine. Then number two, what will happen? As it is a problem or inflammation is occurring in the stomach. So he or she may have gastric upset, gastric upset. Okay. Then third one, if it is advancing into its next level, so he or she may feel pain where in its epigastric region. So pain in epigastric region 4. The patient is not going to a doctor. He is bearing that, okay, this pain will go away anyway. Okay, but let me tolerate this. So he is tolerating. Then the patient can develop nausea and vomiting. Nausea and vomiting. The patient is still not going to a doctor. He is still tolerating. What will happen to him? So what will happen to him? Definitely, then ulcer will develop. Ulcer from gastritis, ulcer will develop. If ulcer develops, then the content of the stomach, it will overflow. It will overflow, or it will be out from its place. So there are two ways where the content of the stomach can be out of its place. Another is mouth and another is rectum anal canal. So when it is in its worst when it is in its worst place, the patient may come to you with a problem that, my doctor, I am having vomiting, but blood is passing with my vomit. So we call it hematemesis. Okay. Then another type of patient may come to you and call you and tell you that, doctor, I am having or I am passing a stool, but my stool is mixed with blood. That is melena. So these two are the last. If a patient finds vomiting with blood or stool with blood, definitely he or she will come to you. So these are the actually symptoms which you don't need to memorize. You think in a way that if this occurs to you, what will be the problems? You already know this. First, you will be asymptomatic, then gastric upset, then pain in the epigastric region, then nausea and vomiting, then ulcer, then hematemesis, and then melena. So till now, we have discussed about gastritis, and then the protective layers of the gastric mucosa, then the damaging factors of the gastric mucosa, and two types of ulcers and the symptoms of the gastritis. Okay, so please let me know in the comment section. Are you enjoying my lecture? And please let me know that should I continue my lectures further, because next topic is peptic ulcer disease with some clinical presentation, and that is very important for you. So till now we have discussed the gastritis. Now, till now, what all the things we have discussed, it's consist of acute gastritis. It consists of acute gastritis. Okay, it is acute gastritis. So now we'll jump to the chronic gastritis. So chronic gastritis, let's talk about chronic gastritis. Okay, let me write here. We'll discuss here chronic gastritis. Chronic gastritis. Okay, chronic gastritis. So actually, what does the word chronic means? Chronic means a patient is having problems for many days. He was having a problem with acute gastritis. He didn't come to you. So he became ill day by day, or he became severely ill day by day. And finally, after 2 or 3 months, or after a chronic period, he or she developed chronic gastritis. Okay. So now, if a patient came to you with a chronic gastritis, he or she or the patient may come to you with some complications. So what are those complications? Complications with may come to you. A patient may come to you with some complications that is actually causing the chronic gastritis. The very first complication and very important complication is H. pylori infection. H. pylori means Helicobacter pylori infection. The second complications is about autoimmune diseases. The third complications is uremia. The fourth complication may be radiation. The fifth complication is the graft versus host disease. So these are the main complications that a patient come to you with chronic gastritis. So let's talk about chronic gastritis. Basically, we divide the chronic gastritis into two types. And one is type A and another is type B. So let's start with this type A. So type A gastritis or chronic type A gastritis. Actually, the word A stands for autoimmune. So many doctors call it autoimmune gastritis or autoimmune chronic gastritis. What happens here? Here, actually, some antibody forms here, and those are autoimmune in nature, and we call it in a way that some autoimmune antibody occurs, and those are manifested by self-reactive CD4 T cells. They are characterized by self-reactive CD4 T cells. What these self-reactive CD4 T cells do? They actually damage the parietal cells of the stomach. Okay, they damage or destruct the parietal cells of the stomach. Now, the parietal cells of the stomach, they mainly secrete the HCl. Though the patient will develop achlorohydria. The patient will develop achlorohydria as self-reactive CD4 T cells has damaged the parietal cells released hydrochloric acid, but now there is no cells. So the patient will develop achlorohydria. When achlorohydria develops in a patient, then another type of cell, that is G cells become stimulated, and G cells secrete so much gastrin, and when so much gastrin comes, it actually occurs that gastrinemia or hypergastrinemia. And this hypergastrinemia is well associated with increased risk of neuroendocrine tumor. So actually what happens, or if a patient come to you with some autoimmune conditions. Now, what are some autoimmune conditions? Autoimmune conditions may be Addison's disease, or it may be Hashimoto thyroiditis, or it may be pernicious anemia, or some other autoimmune diseases. So if a patient came to you with a chronic autoimmune disease, you must remember that the patient may develop some neuroendocrine tumor with this pathophysiology. What is that? Autoimmune disease. With chronic autoimmune disease, the patient develops some self-reactive CD4 T cells, and the self-reactive CD4 T cells ultimately damage the parietal cells of the stomach. Parietal cells used to secrete hydrochloric acid, but when the parietal cells is damaging, the patient will develop achlorohydria. That means there is no hydrochloric acid in its stomach. Then the G cells gets automatically stimulated, and it secretes so much gastrins. So the patient develops hypergastrinemia, and hypergastrinemia is well associated with increased risk of neuroendocrine tumor. So you have to, as a doctor, you have to know, with a patient with this may develop neuroendocrine tumor. We have already learned about type A chronic gastritis or autoimmune chronic gastritis. Now we'll learn about the type B. Okay, let's jump to the type B, chronic gastritis. Chronic gastritis. What happens here? Type B for bacteria. So type B chronic gastritis is well associated with H. pylori infection. H. pylori infection. Okay. But H. pylori infection, what it does, okay, Mr. H. pylori, what it does actually. This H. pylori releases an enzyme, and we name it, or we can tell it in some microbiological language, that is H. pylori has some virulence factor. But out of those 4 or 5 virulence factor, the important and the toxic virulence factor is an enzyme, and the name of that enzyme is urease. Urease. And the urease, it releases some toxic metabolites. And what are some toxic metabolites? That is Kage and Vake. Those toxic metabolites ultimately causes inflammation. And it is not the end. When inflammation is occurring there, obviously the patient will develop gastritis. Okay, obviously the patient will develop gastritis, but this inflammation leads to 3 things actually. This inflammation leads to 3 things or 3 consequences. Number 1 consequences of chronic Helicobacter pylori infection in case of type B chronic gastritis is duodenal ulcer. Duodenal ulcer, where actually gastric metaplasia occurs. Number 2 consequences of the inflammation caused by chronic irritation of the Helicobacter pylori is stomach cancer. Stomach cancer. And the third one, that the Helicobacter pylori causes problems making inflammation, that is reactive T cells. It generates some reactive T cells. And this reactive T cells secrete some factors. What they do? They secrete some factors. And these factors ultimately causes proliferation of polyclonal B cells. B cells. And you have must heard the name or heard the word which I am going to tell you now, that proliferation of polyclonal B cells means actually the patient is having meldoma. What? Meldoma. So your teacher might ask you, tell me what is meldoma. So the answer will be that proliferation of the polyclonal B cell is called meldoma. Why meldoma occurs? Meldoma occurs due to proliferation of polyclonal B cells. Why proliferation of the polyclonal B cells? Because reactive T cells secrete some factors, and it causes proliferation of the polyclonal B cells. Why reactive T cells will come here? Because there is having inflammation caused by urease enzyme and its metabolite, that is Kage and Vage, and this urease is secreted by the H. pylori bacteria. So ultimately, in case of type B chronic gastritis, the patient may develop 3 things: duodenal ulcer, stomach cancer, and meldoma. So we have already discussed the chronic gastritis. Okay, in our next lecture, if you allow me, I will discuss about in very details, the stomach cancer or stomach ulcer or PUD, and also duodenal ulcer. Okay, so I will discuss about this too, but first let me know in the comment section that I should continue your lecture or not. Okay, or if you have any questions, I am available on Facebook. Just search my name, Khalid Mustakim, and you will have a profile picture with several snake. That one is the me, or you may write to me via email, and just simply khalidmustakim@gmail.com if you have any questions, or I am available also on WhatsApp. Comment if you need my WhatsApp number, and I'm also available on Telegram. Okay, and another thing, if you need the PDF of Robbins like this topic, that I need these lectures, or I need this highlighted 4-mark PDF, so just let me know. I will get you to this. Okay, so we are done with gastritis, acute gastritis, chronic gastritis. Then we have also done with the symptoms. Then our next lecture will be on PUD, if you allow me. Okay, I have missed a point here. I just came to know that in case of type A chronic gastritis, teacher may ask you, tell me the common sites of type A chronic gastritis. The common site or common involvement of type A gastritis will be the fundus and body. Okay, fundus and body. And in case of type B gastritis, it is actually affects the antrum. Okay, this is the last point. So thank you all.